Your doctor looked at the number, looked at you, and said the same thing doctors have been saying for 30 years. Your blood pressure is high. We need to start you on medication. And if you asked why, if you sat in that chair and said, "But why is it high? What is actually causing this?" the answer you received was probably one of three things. It runs in your family, it is part of getting older, or we do not always know the cause. I want to tell you right now, in the first 60 seconds of this video, that in the majority of people over 60, that answer is incomplete. Not wrong, exactly. Incomplete in a way that matters enormously, because when you do not know the cause, you cannot address the cause. You can only manage the number. And managing the number while the cause keeps operating is exactly how people end up on 2 blood pressure medications, then 3, wondering why their readings are still climbing despite doing everything they have been told to do. I am Dr. David Miller. I have been practicing medicine for 15 years, and I built this channel on one principle. The healthcare system generates revenue from managing your condition. It does not generate revenue from resolving it. What I do here is explain what is actually happening inside your body in plain language, with enough detail that you can make genuinely informed decisions. Subscribe to Dr. Miller right now and hit that like button. We are working toward a community of people who understand their own physiology instead of simply accepting a prescription and a follow-up in 3 months. Every subscriber makes this channel more visible to someone who needs it. Now let me tell you about a patient I will call Elena. She was 63 years old. She had been on blood pressure medication for 4 years. 1 pill, then 2. Her readings had improved initially and then plateaued at a level her cardiologist described as acceptable but not optimal. She was eating well. She walked every day. She had cut out salt, or believed she had. She came to see me not because she was in crisis, but because she was frustrated. She was doing everything right, and the numbers were not responding the way anyone had told her they should. She wanted to know why. When Elena sat in front of me, I did not start with her blood pressure readings. I started with her kidneys. I asked about her fluid intake, her urine output, whether she ever noticed swelling in her legs and ankles by evening, whether she woke in the night to urinate, and whether she had ever had a comprehensive kidney function panel done in the last 2 years. She had not. Her previous workups had included a standard creatinine measurement, a single number that gives a rough estimate of kidney filtration, and it had come back within normal range. Nobody had looked further. Nobody had connected her kidneys to her blood pressure in any specific or mechanistic way. What I want to do in this video is explain that connection to you completely, because the relationship between the kidneys and blood pressure is not vague or indirect. It is one of the most precisely understood mechanisms in all of cardiovascular medicine. And when that mechanism is dysregulated, no amount of dietary salt restriction, no amount of exercise, and sometimes no amount of medication will bring the numbers down sustainably, because the root of the problem has not been touched. Your kidneys are not simply filters. That is the simplest way to describe them, and it is also the most misleading because it implies a passive function, like a strainer in a sink. Your kidneys are active hormonal organs. They produce hormones, they respond to hormones, and they regulate the volume and composition of every drop of fluid circulating in your body at every moment of the day and night. They are, in the most literal sense, the primary architects of your blood pressure. Not a contributing factor, the primary architects. Here is the mechanism in plain terms. Your blood pressure is determined by 2 things: how much fluid is in your circulatory system and how much resistance your blood vessels are offering to that fluid as it moves through them. Your kidneys control the first variable directly. When the kidneys retain more sodium and water, blood volume rises. When blood volume rises, the heart has to pump harder to move that larger volume through the same network of vessels. Pressure goes up. When the kidneys excrete more sodium and water, blood volume falls, the heart works less hard, and pressure goes down. This is not a slow or subtle mechanism. It is continuous, precise, and operating every minute of your life. The system that governs this process has a name. It is called the renin-angiotensin aldosterone system, and I am going to explain it once in plain language because understanding it is the key to understanding why so many people's blood pressure does not respond adequately to standard treatment. When the kidneys sense that blood pressure is falling, or when they sense that sodium levels in the blood are dropping, they release a substance called renin. Renin is an enzyme, a biological catalyst, that sets off a chain reaction. Renin converts a protein in the blood into a compound called angiotensin 1. Angiotensin 1 is then converted by an enzyme in the lungs into angiotensin 2. And angiotensin 2 does two things simultaneously. It causes the blood vessels throughout the body to constrict, narrowing their diameter and raising resistance. And it signals the adrenal glands, which sit on top of the kidneys, to release a hormone called aldosterone. Aldosterone travels to the kidneys and instructs them to retain sodium and water. More sodium retained, more water retained, higher blood volume, higher pressure. This system exists to protect you. When you stand up quickly, when you lose fluid through sweating or illness, when blood pressure drops transiently for any reason, the renin-angiotensin aldosterone system activates and brings it back up. It is one of the most elegant regulatory mechanisms in human physiology. The problem occurs when this system becomes chronically overactivated in people who do not need the correction it is providing. When the kidneys, for reasons I am about to explain, are releasing renin at elevated levels continuously, signaling the body to retain fluid and constrict vessels even when blood pressure is already adequate or elevated. The system that is supposed to rescue you from low pressure is instead driving your pressure into dangerous territory. And it is doing so from the inside, invisibly, in a way that no dietary change and no lifestyle intervention can fully override, because the signal is coming from the organ itself. Subscribe to Dr. Miller and hit the like button. What I just described, the renin-angiotensin aldosterone system and its role in treatment-resistant hypertension, is the kind of mechanistic explanation that would take a cardiologist or nephrologist 20 minutes to walk through in a clinic appointment they do not have time for. This channel exists to give you that 20 minutes. Hit subscribe and hit like. It costs you nothing, and it means the next person searching for answers to this exact question finds this video instead of a generic recommendation to eat less salt. Now, I want to explain the specific reasons why the kidneys begin overactivating this system after the age of 60, because this is where the research is clear and where the opportunity for intervention is real. The first reason is reduced kidney mass and filtration capacity. By the time a person reaches 60, the kidneys have lost a meaningful percentage of their functional tissue compared to their peak capacity. The nephrons, which are the individual filtration units inside the kidney, number approximately 1 million in each kidney at birth. They do not regenerate. When they are damaged or lost, the remaining nephrons compensate by working harder. This compensation is effective up to a point, which is why standard creatinine measurements often appear normal even when significant nephron loss has occurred. The remaining nephrons are working overtime to produce a normal-looking result. But the compensatory overwork itself creates a state of chronic low-grade intrarenal pressure dysregulation that keeps renin release slightly elevated above what is appropriate, not dramatically elevated. Just enough, sustained over years, to progressively push blood pressure upward in a way that looks like it is simply getting harder to control with age. The second reason is arterial stiffness in the vessels supplying the kidneys themselves. As we age, and particularly in people with years of even mildly elevated blood pressure, the arteries that deliver blood to the kidney tissue lose elasticity. They become stiffer and narrower. The kidneys, receiving slightly less blood flow than they are designed to receive, interpret this reduced perfusion as a signal that systemic blood pressure has dropped. They activate renin release in response. But systemic blood pressure has not dropped. The kidneys are misreading a local delivery problem as a global pressure problem and responding accordingly. They are pressing the accelerator in a car that is already moving too fast, because the sensor that should be reading the speedometer is receiving a false signal. The third reason is chronic low-grade inflammation in the kidney tissue itself, which is among the least discussed and most clinically significant drivers of hypertension in people over 60. The kidneys, like all tissues in the body, are subject to the accumulating inflammatory burden of decades of metabolic activity. In people with even modest elevations in blood sugar over many years, in people with long-standing mild obesity, in people who have carried any degree of metabolic syndrome, the kidney tissue develops a state of persistent low-grade inflammation that directly interferes with the normal regulation of renin release, sodium handling, and fluid balance. The inflamed kidney does not regulate blood pressure normally. It retains more sodium than it should, it activates the renin cascade more readily than it should, and it responds less effectively to the medications designed to suppress that cascade. This is the mechanism behind what cardiologists call resistant hypertension, blood pressure that does not normalize despite multiple medications. In a significant proportion of those cases, the kidneys are not simply a bystander to elevated pressure. They are the active driver of it through a chronically dysregulated inflammatory state that was never directly measured or addressed. Elena's workup, when I ordered a comprehensive kidney panel that went beyond the standard creatinine, showed mildly elevated markers of kidney inflammation and a pattern of sodium retention that was inconsistent with her dietary habits. Her kidneys were holding onto sodium they should have been excreting. Not dramatically, just consistently. Enough to maintain a blood volume slightly higher than it should be, which her heart was compensating for by generating slightly more pressure than it should, which her medications were partially suppressing, which left her in the gray zone of acceptable but not optimal that nobody had bothered to explain. Now I want to tell you about the practical protocol because understanding the mechanism is only valuable if it changes what you do. The first step is getting the right information. A standard blood pressure workup includes a creatinine level, a basic metabolic panel, and perhaps a urinalysis. This is not sufficient to assess the kidney's role in driving blood pressure. What you need additionally is a measurement called the urine albumin to creatinine ratio, which detects the earliest signs of kidney filtration barrier damage, a marker that appears years before creatinine begins to rise. You need a full electrolyte panel, including magnesium, because magnesium deficiency is one of the most common and most overlooked contributors to both kidney dysfunction and blood pressure elevation. And you need a measurement of your aldosterone and renin levels, ideally done in the morning after resting, which can tell you directly whether your renin-angiotensin aldosterone system is chronically overactivated. These tests are not exotic or expensive. They are simply not part of the routine panel that most people receive. Asking your doctor for them specifically, by name, is a reasonable and important step. The second element is dietary magnesium, and I want to spend a moment on this because it is one of the most direct nutritional interventions available for kidney-mediated blood pressure elevation, and it is almost never discussed in a standard clinic visit. Magnesium is required for the proper function of the channels in the kidney tubules that regulate sodium and potassium excretion. When magnesium is deficient, these channels malfunction. The kidney retains sodium more aggressively than it should. Blood volume rises. Pressure rises. Studies consistently show that magnesium supplementation in people with deficiency produces measurable reductions in blood pressure, with effects that are most pronounced in people whose hypertension has a significant renal sodium retention component, which is precisely the population I have been describing. The foods highest in bioavailable magnesium are pumpkin seeds, dark leafy greens, particularly spinach, and Swiss chard, legumes, and dark chocolate above 70% cacao. A daily handful of raw pumpkin seeds is one of the simplest and most evidence-supported dietary interventions for this specific mechanism. The third element is hydration, and the specific timing of hydration, which most people have completely backwards. The kidneys need adequate water to maintain the dilution of urine that allows efficient sodium excretion. When the body is mildly dehydrated, the kidneys conserve water by also conserving sodium, which raises blood volume and pressure. The common pattern I see in patients over 60 is significant underhydration through the morning and early afternoon, followed by larger fluid intake in the evening. This pattern is physiologically counterproductive. The kidneys need consistent hydration through the active hours of the day to maintain normal sodium excretion. The target is consistent small amounts throughout the morning and midday, with fluid intake tapering naturally after late afternoon. Not restricting evening fluid to the point of thirst, which is itself a signal of dehydration that has already occurred, but prioritizing front-loading the day with adequate water so the kidneys are never operating in a conservation mode during their most metabolically active hours. The fourth element is chronic inflammation reduction, which addresses the third mechanism I described, the inflammatory dysregulation of kidney function. The most evidence-supported dietary pattern for reducing renal inflammation is the consistent elimination of ultra-processed foods, refined carbohydrates, and vegetable oils high in omega-6 fatty acids from the daily diet, combined with consistent inclusion of long-chain omega-3 fatty acids from fatty fish, walnuts, and flaxseed. This is not a short-term intervention. The inflammatory state in kidney tissue builds over years and resolves over months to years of consistent dietary change. But the trajectory is real and measurable. Kidney inflammation markers fall, sodium handling normalizes, blood pressure becomes more responsive to both lifestyle and medication. The ground that looked fixed begins to move. How old are you? Write your age in the comments right now. I want to know the age range of the people watching this channel because it shapes what I cover next. If the majority of you are in your early 60s, I want to go deeper on the early detection of kidney involvement in blood pressure dysregulation, the tests to ask for, and what the results mean. If many of you are in your 70s, I want to address what the research shows about how aggressively blood pressure should be managed at that stage, because the target numbers are more nuanced than most people have been told, and the evidence has shifted significantly in the last 5 years. Elena came back to see me 5 months after our first appointment. She had added magnesium-rich foods consistently. She had restructured her fluid intake toward the morning hours. She had worked with a functional medicine colleague of mine to address her kidney inflammation markers through dietary change. Her aldosterone to renin ratio, which had been elevated at our first visit, had normalized. Her blood pressure readings, which had been sitting in the 145 to 150 systolic range despite 2 medications, were now consistently in the 128 to 132 range on the same medications. Her cardiologist, at her next visit, reduced one of her medications to a lower dose, not because the medications had suddenly become more effective, because the underlying renal mechanism that had been driving her pressure upward had been partially corrected, and the medications were now working against a smaller problem. Your blood pressure is not simply a number that your genes determined and your medications manage. It is the output of a living regulatory system, and the kidneys sit at the center of that system with more influence over the final result than any other single organ. When the kidney component of blood pressure regulation is dysregulated, managing the number without addressing the organ is like turning down the volume on a fire alarm while the fire continues to burn. The alarm goes quieter, the fire does not stop. I am Dr. David Miller, and I have spent 15 years watching patients accept a diagnosis of essential hypertension, which simply means high blood pressure of unknown cause, and live on escalating medication doses for the rest of their lives without anyone sitting down to explain what was actually driving the number upward. The mechanism I described today is not obscure or experimental. It is foundational cardiovascular physiology that every cardiologist and nephrologist learns in medical training. The gap is not in the science. The gap is in the conversation. Subscribe to Dr. Miller. Hit the like button. Share this with someone who has been told their blood pressure is just something they have to manage forever. Forever is a long time to manage something whose cause has never been properly investigated. The healthcare system profits from keeping you on that treadmill. I profit from you stepping off it. Subscribe if that difference matters to you. This content is educational in nature and does not constitute personalized medical advice. If you have high blood pressure or kidney concerns, please speak with your physician before making changes to your medications or treatment plan. The mechanisms and interventions discussed here should be explored in partnership with a qualified healthcare provider who knows your individual medical history.